Hello, as we continue on, this is the first independent lecture in our hemodynamics series of lectures. Um, this particular lecture, I'm going to look at what is basic hemodynamics, what is the function of valves as it pertains to hemodynamics, and just what are the basic hemodynamic values that we look at. We'll look at what the normal pressures are in the different portions of the heart, and we'll answer some common questions as we go through. So hemodynamics involves the study of blood flow as it travels through the vascular and the pulmonary system. Now, a lot of people think that hemodynamics involves just the measurement or monitoring of pressures. And while this is true, the monitoring and measurement is not just of pressures. We measure pressure, usually it's in millimeters of mercury. We can measure volume. A lot of the time, the volume that we measure is going to be in liters per minute. It can also be just in liters. It can be in milliliters. It can be in milliliters per minute. It can be in milliliters per beat, depending on what we're looking at. Resistances. The resistances that we primarily look at when we're looking at hemodynamics are going to be the force which is pushing back against the ventricle as the ventricle is attempting to pump blood out. Now, resistances are commonly measured in a very, very abstract unit that a lot of people have never heard of, and the common unit that are used to measure resistances are dynes per second per centimeter raised to the negative fifth. Unfortunately, there's really no better way to remember that. If you've got one, put it in the comments. I'm all about it. But it's just one of those things that you're going to have to memorize. A dyne is a very, very small unit of force. And because we're measuring flowing blood, we have to do this in force per unit of time. And the reason we have these centimeters to the negative fifth is because it's such a small volume and such a small force. Preload pertains to the amount of force that is attempting to fill a ventricle, or the amount of force that is attempting to push the blood forward, while afterload is the exact opposite. Afterload is directly related to resistance. The afterload is the amount of force that a ventricle must pump against to move blood from one area to another. So preload is kind of its own thing. We don't directly measure it, or we don't directly calculate it, but preload is going to be the pressure the pressure that is assisting to fill, while the afterload is actually going to be pretty related to the resistance after the particular area we're looking at. And as we continue on with hemodynamics, we'll look at each one of these: pressure, volume, resistance, preload, and afterload, in all of the different systems that we're going to assess. With this, not to add a new level of confusion, but every value, with the exception of pressure, can be expressed not only in the value that you're given, i.e. a normal cardiac output, a normal vascular resistance, but we can also relate that to the patient's specific size or the patient's body surface area. And when we relate these things to the patient's specific size or the body surface area, then that value is referred to as an index. For example, if we're looking at the amount of blood that is pumped out of the heart in 1 minute, we're looking at the cardiac output. But if we take the cardiac output and compare that with the patient's actual size in meters squared, so we look at the skin surface area in meters squared, then that converts that value to a cardiac index. The same thing can be said for measuring the resistance of blood as it passes through the lungs. Normally, we measure the resistance of blood just based on the cardiac output, and we'll get into this a little later, just based on the cardiac output and the pressures, and that is a pulmonary vascular resistance. But when we compare that value to the patient's size or the body surface area, then that is considered a pulmonary vascular resistance index. Unfortunately, the normal values for the raw data or the non-compared to the patient size values are completely different than the index values. So unfortunately, it's one of those things that you just have got to get used to, but more to remember. But the benefits that we have to using a an index is that an index allows us to compare two different patients that are dramatically different sizes. For example, if I have a 60 kilogram adult, that's a smaller adult, either a smaller woman or a smaller man, doesn't matter, and then I have a 200 kilogram adult, you would be very, very hard pressed to compare any cardiac output data, any cardiac any raw data, any volumes for one patient compared to the other. But if you then take into account the physical size of the patient, then you can begin to compare these two. We don't tend to use indexes a lot when it comes to hemodynamics, but books like to talk about them. And whenever you get into case studies, the professors particularly like to use indexes because it's one more thing that you have to convert to. And unfortunately, it's one more area where you can make a mistake or just altogether forget to do it. So when we look at hemodynamics, the question I get from a lot of students is, how many different pressures can there possibly be? You have one heart, you have 4 chambers. Really, how much? Come on. Well, in short, each chamber of the heart has its own normal values. So you have one chamber here, it has its own normal values. Let me switch to a different color. Another chamber here has its own normal values. Another chamber here, its own normal values, and another chamber here with its own normal values as well. But in addition to this, you have to look at what it's pumping to. So you also have another system here, the systemic system in your aorta. Then you have another system here, your pulmonary system. So you're going to have a total of 6, 1, 2, 3, 4, 5, 6 different pressures and 6 different systems to work at. This is particularly important because when we begin to look at hemodynamic case studies, you can really pinpoint where the problem is based on normal and abnormal values as you progress through the heart. Now, it should be mentioned that things in blue in this picture tend to be low pressure areas. They also tend to be referred to, the venous system here is systemic, the arterial system here is systemic, and then you have a separate system for your pulmonary circulation. Your pulmonary circulation, the definition of it varies depending on the textbook you look at. Some people consider the pulmonary circulation everything from the right ventricle out to the pulmonary veins. However, some people consider the pulmonary circulation anything from the pulmonary artery on. In my opinion, the right ventricle directly pertains to the pulmonary circulation, so I normally consider the pulmonary circulation the right ventricle all the way to the pulmonary veins, and the systemic circulation anything from the left atrium all the way through the body and all the way back to the right atrium. When we examine hemodynamic values, there are some trends that we can look at based on whether we expect the values to be high or we expect the values to be low. Just like I said, traditionally the values originating on the right side of the heart, i.e. the right ventricle, the right atrium, tend to be lower than the pressures that originate from the left side of the heart, the left atrium, the left ventricle. Certain parts of the heart are only defined by their mean pressure because they don't pump. And i.e. the atria, they have a small kick and they pump just a little bit. But as I mentioned in one of the previous lectures, the atrium don't really directly pump. They contract a little bit to aid with ventricular filling, but there's no specific large pump. So the atria, in addition to the venous system, we just tend to measure their average or their mean pressure, and that's the pressure that we use when we calculate everything else out. However, when we look at the ventricles, because they pump, and the main arteries, i.e. the pulmonary artery and the aorta, because those pressures occur as a result of pumping, then we tend to use the systolic pressure, which is the high pumping pressure, the diastolic pressure, which is the lowest pressure that's achieved in the system, and then the mean pressure, which is the average pressure between the two. I kind of argued as to when to mention this, but we'll be going over a lot of formulas, particularly when we get into different systems. So the systolic pressure, like we said, let's go to a good color pen. I like green. The systolic pressure, like we said, is going to be the highest pressure. The diastolic pressure is going to be the lowest pressure in the system. And then the mean pressure, which is commonly displayed in parentheses off to the side, is the average pressure in the system. But the thing that's important to mention is the mean is not systolic plus diastolic divided by 2. The reason this is not the case is because the heart stays in the diastolic phase for twice as long as it does in the systolic phase. The reason for this is the heart pumps and it relaxes. And then it pumps and it relaxes. And then it pumps and it relaxes. So it spends twice as long in the diastolic phase versus the systolic phase. So to calculate the mean pressure, the mean blood pressure is a result of the systolic blood pressure plus the diastolic blood pressure times 2, and then the whole thing divided by 3 total parts. And we'll get into what the specific normal values are for both the pulmonary blood pressure and the systemic blood pressure here in just a minute. But I think this is a good point to mention, or a good part to mention, that there is a major structure in the heart that is responsible for a lot of our hemodynamic values, and in adults and pediatric patients, it tends to cause a lot of issues, which does result in the requirement for surgical intervention. These particular things are valves. A lot of people have heard of valves, but they don't really understand. They understand that valves prevent blood backflow, but they don't really understand that the structure of the valve is different based on where it is. Now you have 4 valves in your heart. The 4 valves that you have in your heart, they range, there's 3 different tricuspid valves and 1 bicuspid valve. They're referred to commonly as other things. Some people refer to them as atrioventricular valves. Some people refer to them as semilunar valves. I've seen textbooks that do it both ways. I've also seen professors that refer to it both ways. You're going to have to kind of learn what the particular professor or where you work, how they refer to it, but I just refer to them by their name. So, the 4 valves that you have, as the blood passes from, let's go to a good color here, as the blood passes from the right atrium into the right ventricle, you have the tricuspid valve. The tricuspid valve, as you can see, has 3 cusps. It's also right over here. As you can see, there's a cusp, is a small section of the valve. Better color. It's a small section of the valve that comes together to allow the valve to separate to aid in blood flow passing. So you can see that there's 3 cusps, 1 here, 2 here, and 3 here in the tricuspid valve. Now, the reason that a valve is either tricuspid or bicuspid is based primarily on its function. What I mean by this is the more cusps a valve has, i.e. tricuspid over bicuspid, the more blood is going to be able to move through it, because a tricuspid valve compared to a bicuspid valve, as you can see right here, the tricuspid valve is able to open more to allow more blood to pass through. Now you would think, oh, well, we would always want the blood to pass through as easily as possible with as little interference as possible. But that's not always the case, and when we get into the normal values and the normal pressures, you'll see that that's not always the best thing. So, as we continue on, we have the right atrium, the tricuspid valve, the right ventricle. And as the right ventricle contracts, the blood is ejected through the pulmonary valve, which, as you can see up here, is another tricuspid valve. 1, 2, and 3. So 3 cusps there. The blood goes out to the lungs, and it comes back via the 4 pulmonary veins. 1, 2, and there's 2 more on the posterior portion of the heart. 3, 4, and it all drains into the left atrium. The left atrium, there's no valves that separate the pulmonary veins into the left atrium. It just flows via a pressure gradient. The blood then flows through the mitral valve, which is the only bicuspid valve we have in our heart. The bicuspid valve, as you can see, has a dramatically different structure. It only has 1 cusp here and a second cusp here, creating what I think looks like a bit of a half moon. You can see up here in the names, and I just got this picture off of Google, I believe it was. They refer to the aortic and the pulmonary valve as semilunar valves. To be honest with you, I've never really understood this because there is nothing about this or this to me which makes me say, hey, that looks like half a moon. But apparently someone saw it, and I'm just not that abstract. I would think that this over here, the mitral valve, would look more like a semi-lunar valve or a half-moon valve, but who am I? So, as the blood progresses through the mitral valve, which is our only bicuspid valve in the heart, then the left ventricle will contract, and as the left ventricle contracts, the blood is ejected through the aortic valve, which is another tricuspid valve, as you can see it right here. 1, 2, and 3. And then it's ejected out to the body. When we look at each particular valve, and I don't like to put a video within a video. It's kind of like one of those, the movie was called Inception, where you had to go in a dream within a dream, but that's a side thing, I guess. I did want to put this video in here because I thought it was very, very good, and it showed the structure and the function of a valve while it was actively being used. And I do want to use this particular video here to kind of give an idea of what the different components of the valves are. So I'm going to go right here. I'm just going to pause the video for just a second. And I want to go in and label 3 different portions. There's one portion of the valve. Oh, there we go. Sorry. One portion of the valve, which is right here. And this first portion is going to be the papillary muscle. The papillary muscle is responsible for connecting the actual muscle of the heart to the valve, and in doing that, it actually creates a small connection so that the cardiac conduction system is able to innervate this muscle and aid in the opening of the valve whenever the cardiac muscle contracts in itself. The second portion of the valve is right here. It looks like kind of a spider vein. I really think it's kind of cool. This is called the chordae tendineae. The chordae tendineae, if you ever feel it, if you can get a heart outside the body, it feels very, very similar to what I would imagine Spider-Man's web would feel like. you have to throw a little nerd in here every once in a while. The chordae is responsible for connecting the papillary muscle to the posterior portion of the valve. Now, this is very important because the chordae, it is made of connective tissue, but there's a lot of collagen tissue in there. So it's very, very stretchy, and it moves around a lot, and it's very, very fibrous. But if you grab it and stretch it, you can easily stretch it to twice as long as it is when it's at rest. With this, the third portion you have is the actual connective tissue valve that's there in itself. Unfortunately, this particular picture, it shows the third cusp, which would be right here, removed, just so you can get an idea of the normal function of the valve with blood flowing through it. But the connective tissue here, it's just made primarily of fibrous and collagen tissue. It's very, very tough. If I were to give it an actual consistency, it would be similar to gristle on steak, things like that. I know no one likes to, ooh, I'm gonna go and chew through a nice heart valve, but whatever you're into. So, the primary function of the valves, we have a few primary functions. The first one is to separate the chambers of the heart, which it does primarily just based on its physical presence. With this, because blood only flows in one direction, it prevents backflow. Now, to do this, I'm going to restart the video, and we can talk about it here. So, as the blood pumps, or as the ventricle pumps, the ventricle contracts. As it contracts, the papillary muscles allow the valve to close. So as this goes up, the valve closes. Okay? So with this, as the ventricle contracts, it forces the pressure on the inside of the ventricle here to increase. As it forces the pressure on the inside of the ventricle to increase, the valve is closed and the blood is ejected to whichever distal portion there is. But with this, as the valve closes, blood backflow is prevented. And there's a second thing that a lot of people don't think about, and this gets particularly important as you consider a lot of the pediatric cardiac anomalies, because there are a few congenital cardiac repair surgeries that will completely remove a valve. And it's not that it's good to remove a valve, it's just better than the option. So, as we go on, the third function of a valve is to maintain the diastolic pressure. Now, if you guys remember back from the previous slide where I was talking about the calculation for mean blood pressure, which is systolic plus diastolic times 2 divided by 3. Now, if you consider that you have a normal valve and the diastolic pressure is maintained at whatever the normal value is, everything's going to be all well and good. But you also have to consider that if something were to happen and the valve were to be removed or the valve were to be non-functional, an abnormally low diastolic pressure is really going to affect the mean blood pressure in that particular area. How this is relevant, and I'm not really going to go into great detail into organ perfusion and cellular perfusion, but your mean blood pressure in both your arterial, your systemic, and your pulmonary system is going to be your primary perfusing pressure. The reason for this is the farther you get away from a pump, the less oomph you see from the particular contraction. So if this is my very, very bad attempt at drawing an arterial waveform, you see the pressure goes up. Each one of these is a heartbeat, 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 heartbeat. The average pressure, this is going to be the mean blood pressure. So the average pressure is going to be the pressure that is represented at the distalmost section of the system, which is going to be your primary perfusing pressure. Now, if you consider that the diastolic pressure is lower than it should be because of a valve malfunctioning, then consider that the pressure goes all the way down, then comes back up, and all the way down, and then comes back up. So then your diastolic pressure is going to be much lower, and because your heart spends more time in the diastolic phase, twice as long as the systolic phase, you're going to have a much greater effect on your overall mean blood pressure, and thus an overall greater effect on distal organ perfusing pressure. I know this, like I said before, it seems very, very abstract, but as we get into it, it becomes a lot clearer. So, as we consider the hemodynamic values, unfortunately, most hemodynamic values are not named based on where they're measured. And I know that seems very inconvenient, but some of them are. So the right atrium is referred to as the central venous pressure. The right atrium, or the central venous pressure, and I didn't put this in here, but it's just a mean blood pressure. It's measured in the right atrium, and it's commonly measured using just a central venous catheter. I've got another lecture that I'm putting together that's looking at types of vascular access, and it's just going to be very, very brief. We'll talk about the Swan-Ganz catheter. We'll talk about the different central venous catheters, and we'll talk about the different peripheral arterial catheters. Like I said, it'll be very brief just to kind of give you an idea. As you move through the heart, you move into the right ventricle. The right ventricle, we don't so much look at the mean in the right ventricle, but we do look at the systolic pressure and the diastolic pressure, so the high pressure and the low pressure, because the right ventricle contracts. As the blood is pumped from the right ventricle to the pulmonary artery, now we're going to look at the systolic pressure and the diastolic pressure, but because we have some sort of distal organ perfusion, i.e. the perfusion that occurs at the pulmonary capillaries, now we're going to start looking at the mean blood pressure. So, you have the diastolic and the systolic and the mean blood pressure all in the pulmonary system. As the blood is pumped through the pulmonary capillaries and returns to the left side of the heart via the left atrium, we look at the left atrial pressure. The left atrial pressure is very, very difficult to measure, partly because of its location. So we tend to measure it via a secondary source, which is a pulmonary capillary wedge pressure. I'm not really going to get into how that's measured right now. We'll get into that when we look at the types of vascular access. But the pulmonary capillary wedge pressure, just remember, it is akin to the left atrial pressure. That's what it's meant to represent. But it should be mentioned that in some open heart, primarily pediatric cardiothoracic procedures, because they have to be in there anyway, and because pediatric patients don't really tolerate large, Swan-Ganz catheters and things like that, we do tend to occasionally place a pressure probe in the left atrium that can be removed without any sort of surgical intervention, similar to artificial pacing wires, temporary pacing wires, that kind of thing. As the blood is pumped from the left atrium into the left ventricle, then we begin to look at the left ventricular pressure. And remember, the left atrium does not pump, so we just have a mean blood pressure there. But the left ventricle does pump, so then we have the systolic and the diastolic pressure. But there's nothing being perfused in this particular system, so we don't worry about any mean pressure. Then as the blood is propelled from the left ventricle into the aorta, which is also the systemic blood pressure or the systemic system, now we have the systolic pressure, just like the left ventricle, the diastolic pressure, just like the left ventricle, but now because we have distal organ perfusion, i.e. the systemic capillary beds, now we're also going to worry about a mean pressure as well. So as you progress, it gets a little bit more complicated, but I generally like to separate it out like this. Right atrium, very, very similar to the left atrium. Actually, the values are pretty similar as well. Right ventricle, very similar to the left ventricle, although the values, while proportional, are very different. And then the pulmonary artery, similar to the aorta, while the values, like I said before, are very different, but you see the trend. The last thing that I want to look at for this particular talk is what are the normal values in each particular area of the heart. The thing that I want to mention first is these values do vary a lot based on which textbook you're looking at. Usually they're plus or minus 10%, but I've seen some professors and some anatomists get pretty picky with, this is the right value. I've seen normal values vary greatly, but to be honest, in my opinion and in my history with working with a lot of hemodynamics and pediatric cardiac patients, it's not the specific number you look at. Because if a normal value is 2 to 6, you're not looking at an abnormal value being 7. You're looking at an abnormal value being 20 or 25. If a normal mean pressure is 70, you're looking at an abnormal mean pressure of being 50 or 40 or 30, something that's obviously different. So don't really get caught up in the semantics of the specific, 2 to 6, 2 to 5, 3 to 7, things like that. But make sure you remember what about the normal range is. Also, for the National Board for Respiratory Care exams, unfortunately, they tend to have you working, as I believe the Kettering people say, in the NBRC hospital, which means that a value that is different by 1 or 2 compared to what they consider normal, it doesn't matter if it's 1 or 2 different or 400 different, which is never going to be 400 different. But it doesn't matter if the value differs by 1 or 2 or 400, abnormal is abnormal. So you need to consider what you're looking at this for, whether it's the real life or whether it's some exam you're trying to get through. And I hate to really throw that spin on there, but unfortunately, it is the world we live in. So, let's go with white to start with. So the blood pressure, if you remember, that's measured in the right atrium is the central venous pressure. The central venous pressure and the normal values I'm going to give you here are all going to be in millimeters of mercury. The other value that is used occasionally is centimeters of water pressure, but I've only really used that once in my career, and that was in a fairly remote hospital in Egypt where we didn't have any sort of pressure monitoring system. We had to do everything kind of eyed up. So most places use millimeters of mercury. There is a conversion factor. I'll put it in the notes down at the bottom. A normal central venous pressure is anywhere between 2 to 6 millimeters of mercury. Now remember that this doesn't pump, so it's just one mean pressure that we're looking at. Now the right ventricle does pump, so we have a systolic and a diastolic pressure, and then there's going to be a mean pressure, but we won't really look at it just because it's not super relevant to life as we know it. So the normal systolic pressure is going to be anywhere between 15 and 30. The diastolic pressure is going to be anywhere between 0 and 6. The trend that I want you to note is the mean value for the central venous pressure is higher than the diastolic pressure. The reason for this is if there's not a pressure gradient, as in if the pressure is not higher in the right atrium compared to the diastolic pressure in the right ventricle, then there's going to be no blood flow. So if the diastolic pressure is higher here, then the blood will not flow from here to here. I know this seems very, very abstract, but just remember that blood only flows down a pressure gradient. It's just like water is not going to flow up a stream. Water is not going to flow up a hill. So you must have a downward pressure gradient. So as the blood moves into the pulmonary artery, what you can look and see is that you also have a systolic and a diastolic pressure. Your systolic pressure is anywhere between 15 to 30, which should look very, very similar to your systolic pressure in your right ventricle. Your diastolic pressure is going to be anywhere between 8 and 15, and once again, these are in millimeters of mercury. And because we have some sort of perfusion that we're worried about in our system, we look at the average, or the mean, which is going to be 9 to 18 millimeters of mercury. So this is particularly important because you look at the systolic pressure, and it's the same as the systolic pressure in the ventricle because pressure is transmitted. But as the ventricle begins to relax, after pumping this 15 to 30 millimeters of mercury, what you see is the valve closes and the diastolic pressure of 8 to 15 is maintained. And that gives us our average of 9 to 18 millimeters of mercury. The blood goes off to the lungs and it enjoys this mean pressure of 9 to 18 millimeters of mercury. Then comes back to the heart via the 4 pulmonary veins, 1, 2, 3, 4, into the left atrium, and we measure either the left atrial pressure or the pulmonary capillary wedge pressure, which they're both the same thing. They're just this one, I'll put a little asterisk next to it because it's not the pulmonary capillary wedge pressure, like I said, is an indirect measurement of what we expect the left atrial pressure to be. So, normal left atrial pressure is anywhere between 4 to 12 millimeters of mercury. Then the blood flows into the left ventricle. Now, the left ventricle is a pumping chamber, so we have both a systolic and a diastolic pressure. And the diastolic pressure, go ahead and test yourself, is the diastolic pressure going to be higher or lower than the pressure in the left atrium? Well, the diastolic pressure, which is the low pressure, must be below the pressure that's here in the left atrium. So your diastolic pressure is going to be anywhere between 0 to 10 millimeters of mercury. Now, I'm going to do this a little bit differently. Normally, I would just give you the normal systolic pressure here, but I want you to kind of figure this out. Because this is my way of telling you, you don't need to remember all of these values. You can extrapolate a lot of them. So when you look at the systemic system, you know that you have, I'm just going to put it up here, it's a little bit more room to write. You have a systolic pressure, a diastolic pressure, and then you're going to have a mean pressure as well. Well, most people remember what a normal systolic blood pressure is. Most people remember 120 over 80. But 120 over 80, if you're 121 over 79, you're not in imminent danger of, falling out or dying. So we tend to accept anywhere between 110 to 130 for a normal systolic pressure. And so that's your 120. And then for 80, we tend to accept anywhere between 70 and 90 millimeters of mercury. And this gives you a mean blood pressure of anywhere between 80 to 100. Now, how this is particularly important is most people remember the 120 over 80, and if you remember, based on the right side of the heart, that the systolic pressure is transmitted from the pumping chamber to the perfusion system, i.e. the right ventricle to the pulmonary artery, then you know that the systolic pressure in the left ventricle is also going to be the same as in the pumping chamber. So over here we have as well 110 to 130. So to sum it up, central venous pressure is higher than the diastolic pressure in the right ventricle. Then the right ventricle pumps, propels the blood through the pulmonary valve, and its maximum pressure you get is a systolic pressure. You get your pulmonary pressures, which are as a result of your ventricle contracting for your systolic pressure, and then your valve placement, which results in your diastolic pressure. Blood comes back from the lungs, produces the left atrial pressure or the pulmonary capillary wedge pressure. This is higher than the diastolic pressure in the left ventricle. The left ventricle then contracts. When it contracts, it forces the blood through the aortic valve. When it forces it through the aortic valve, the highest pressure achieved is the systolic pressure. Then, as it propels, the systolic pressure is transmitted through the valve, and as the ventricle begins to relax, the diastolic pressure is maintained by the aortic valve. So, in short, the things that I think that are very important, you just need to remember what's higher and what's lower, and that as far as, exams are concerned and as far as real life is concerned, any mean blood pressure equals organ perfusion. I cannot tell you how important that is to life, especially when we start looking at pediatric cardiac surgery. And in pediatric cardiac surgery, a lot of the time you have to tolerate very, very large differences in systolic and diastolic pressure, but we're not concerned with that. We're only concerned with the mean blood pressure. So I'm going to cut us off here. I hope this helped. If you have any questions, put them in the comments. Thank you very, very much, and have a good day.